Well, I'm here with Dr. Clayton Mitchell, who is a pharmacist, and he's going to talk to us today about um, pharmaceutical ethics, medical ethics to his degree of knowledge, which is vast, and I'm looking forward to what he has to say to us. Clay, thanks for coming and talking to our class. Just start out by, first of all, explaining your degree, the kind of the program at Lipscomb that you were in, and what your day-to-day job is and how you go about your everyday work.
Sure. Well, first off, thank you for asking me to participate in this venture. And so, as you've already mentioned, I am a pharmacist. I have my Doctor of Pharmacy degree, which would a lot of times be referred to as a PharmD, but most commonly I'm just referred to as a pharmacist. But my background includes work in community pharmacy settings, and now here recently, since graduating from pharmacy school, I am a pharmacy resident, which in my case means that I'm practicing in more of an inpatient or hospital environment. So that's a little bit about kind of what I'm doing right now. As you mentioned, I am a graduate of Lipscomb's College of Pharmacy, so I did have the benefit of going to an institution that had an emphasis on faith. Even if everyone's faith wasn't exactly my beliefs, it was nice to be surrounded by people of faith all the time when I was there.
Yeah. So it's safe to say that in your line of work, you see it all. I mean, people are coming to you for all different types of medications and advice on their medications. Do you ever have opportunities? I know when I pull up to get the drugs or the prescriptions or whatever, they always ask, do you have questions for the pharmacist? And I never know what to ask, but I guess you have a lot of experience talking to patients about how to use their drugs and what it's being used for, make sure that they have a good understanding of what they're taking.
Yeah, absolutely. So, that's one thing that I'll probably comment on at another point throughout this, but, whenever you pull up to a retail pharmacy like that, if you're picking up a new prescription, you should really expect that the pharmacist will come and speak to you. Now, if you're picking up refills, it might just be a technician or somebody who asks you if you have questions. But you're obligated. So in my case, when I was a pharmacy intern working in a community setting, I was obligated to provide counseling to patients, sometimes who didn't really care what I had to say, and sometimes who they do have the right to outright deny counseling. So, I talk to people in all kinds of different situations, from very mundane allergies to very complex treatment regimens and things of that nature. So I have to be prepared to talk to a whole myriad of issues on a daily basis.
Yeah. Well, let's get right into it as far as the ethical side of things. I sent you a couple of questions that I said we were going to talk about because our textbook talks about these, and I was mentioning it to you before we started recording this, that our textbook is very one-sided for a lot of reasons. First of all, because it comes from a religious standpoint. We're looking at Christian ethics, and so emphasis on Christian there. The second is the author of our textbook served on the medical ethics board of a hospital, and I don't remember how many years he did that, but it was for some time. So he was obviously faced with a lot of these issues, and that's why I wanted to get you and others in to talk about it from your standpoint. You might agree in some of these places, I'm sure in several, because you are Christian, but you might differ on some things. So the first thing that I want to ask you about, get your opinion as a pharmacist on, is your stance on birth control. And I know that's a broad term. There's all kinds of birth control, from the pill to IUDs and all kinds of things. Hormone altering. So what is your view on that? And what do you do when you have young people who aren't married, teenagers, or I don't even know if preteens would get on it or not. Maybe in some instances, I don't know. But that's why you're here to talk about it. So give me your thoughts on that issue.
Sure. So, I definitely do have views on this. And essentially, the first thing that I would comment on is that there's a host of different reasons why somebody could be on a form of hormonal contraception, as I'll refer to it as, because that kind of covers the topic pretty broadly, is to refer to it in that manner. Especially if you see a teenager or obviously a teenage female being placed on these medications, there in certain circles that might raise some eyebrows. But there really are a lot of reasons why somebody could be placed on this, other than just because they're sexually active.
Right.
Females can be placed on these therapies in order to treat acne or hormonal issues. So like polycystic ovarian syndrome. There's certain reasons to be placed on these other than just for issues that are sexual in nature.
Mm-hmm.
So those are some things that I would definitely consider. But in those situations, a lot of times you might have a parent who's picking it up, or it might be the individual with a parent, if they're under the age of, say, 16 and can't drive themselves to a pharmacy. And so in my time in a community setting, I had obviously several opportunities where I had to, be prepared to counsel these people. And so one of my first questions is, for what reason were you placed on this? Mm-hmm. And sometimes they might shy away from that question, and maybe in that instance it might be because they had requested hormonal contraception for the purpose of contraception. And if that's the case, that's fine. I know when to give something a let alone, and just kind of go into telling them what they need to know and move along. Mm-hmm. But sometimes they'll say, oh, it's to treat acne, or it's for this other hormonal situation that's being treated. And so those are just obviously delicate situations that I tried to obviously approach in a way to make sure that information flows both kind of in a two-way street. I need information from the patient, but more so they need information from me. And so I want to be able to provide that to them and make sure that regardless of what their reason for using it is, that they do so safely and effectively.
Yeah, so talk a little bit about some of these birth controls, contraceptions that have abortive qualities.
Sure.
That's something that our textbook is very against, but and you've even mentioned it several times in our conversation so far that it's the patient, if I can use that term, who has to make the decision, or their doctor has made the decision. You're kind of the middleman between them and the drugs.
Sure.
So how do you handle when someone comes to the pharmacy and asks for a Plan B pill or something like that?
Sure. So first off, the Plan B pills, we'll start there. Mm-hmm. And essentially those are hormonal in nature, and they are a form of contraception. But those cannot be used if implantation has occurred. And so essentially what that, particularly, if we're talking about what can be purchased over the counter, because there's a lot of options that a woman or anybody could go and purchase by simply walking down the aisle of a grocery store, and they would not necessarily even have to come visit me at a pharmacy counter. They can just walk right up there, grab that for themselves, check out at self-checkout, and be gone. So they may never even interact with me on that.
Okay.
But with those products, those are not abortive in nature. If implantation has occurred, they will have no effect. And so, obviously in a situation where those are being used, a lot of times there might have been poor judgment used in the lead up to that. Mm-hmm. But I would not necessarily condemn those from the standpoint of them being abortive in nature.
Gotcha.
In some of my research, I've even come across commentary that indicates that things like IUDs are abortive in nature.
Right.
And the reality is that, once again, it's kind of the same situation. The only difference really is that those are implanted permanently, or semi-permanently, we mm-hmm. could say. But essentially, they also work through a hormonal mechanism that, once again, is not fully capable. No method of this is 100% effective, right. But it is not abortive in nature. And if someone was to become pregnant while having an IUD, usually the process is that is removed, and the pregnancy can safely continue in lots of cases, and there's no risk to that. So, those are, depending on what resources you look at and what nature, especially if they're just a really conservative resource, mm-hmm. Almost like an alt-right extreme conservatism situation, you might see some things referred to in ways that or some of these products referred to as being abortive in nature, and they're really not. Mm-hmm. So I would encourage anyone who has questions about this to do your research, speak to a medical professional, and really understand before you dive in, especially if you're planning on speaking to somebody about you thinking that they're in the wrong for using one of these products. Make sure that you know what you're talking about before you speak to that person.
Yeah, so that's one of the steps in our textbook, and our students will be writing a paper on certain issues, certain ethical issues. One of the steps that they have to do is gather the information. So guys listening to this, make sure that you gather your information from multiple sources, credible sources, and go from there. Clay, let's move on to talk about something a little bit different. It's no question that in the realm of pharmaceuticals, the opioid crisis is on the rise, has been on the rise, and is at an all-time high, it seems. So as a pharmacist, there are people who need those drugs and can't get them because of this crisis, because of the limiting of the prescriptions. So as you see the opioid crisis, could you speak a little bit about what it is, and then tell us a little bit about how we might work to resolve this issue? And I'm sure it's going to go well beyond our conversation here to resolve something like this, but just speak to that for just a minute.
Sure. This is certainly an issue that I wish as an individual, I wish I had more power over, because this is something that is very disheartening to see have had happened. And even I was doing persuasive essays and things like this even back when I was in undergrad. So this is something that's kind of been on my radar for a long time. So the opioid crisis initially began when pharmaceutical companies in the early 90s, maybe late 80s, had developed new like synthetic opioid products, which they were heavily marketing as being less addictive than the products of the past that people were known to have had addiction issues with. I think of morphine and drugs like that have been around for a good while. These new products were touted as being less addictive, or in some cases non-addictive, and prescribers kind of took that and ran with it. And to the prescribers' credit, they were working with the information that they were given directly from pharmaceutical companies. And so what this resulted in was these prescribers, it could be doctors, nurse practitioners, physician's assistants, who chose to treat their patients with these drugs thinking that they were doing right by their patient. I really don't think any of this started with any prescribers acting with ill will. Pharmaceutical companies might be a different question, but maybe there was an aspect of ignorance there. But what you ended up with was a large population of patients who ultimately did become addicted, and then it became kind of a slippery slope where we saw an increase in the level of these substances becoming higher level controlled substances, which is intended to kind of curb the access to these products, you could say. And so, like you've already mentioned, what that resulted in was some people who had legitimate need, there's now all this red tape for them to go through to get these products when they truly do need it for pain relief. And really the most appropriate way to use an opioid is really only for short-term treatment of pain. These really, especially now with the knowledge that we have now, these should really, in a lot of cases, we should be trying to avoid using these drugs for long-term chronic pain, because there's evidence that there's psychosocial therapy, even just anti-inflammatories and acetaminophen, things along those lines have been shown to be really effective at treating long-term pain, so long as there's not the component of that pain that's now gotten into this patient's mind, which is that addiction component, which requires these high-strength opioids in order to get them past that. And so I'll try to kind of summarize all this and wrap this up and not go on too long about this, but it really is a big issue, especially here in the area where me and you live, which is Middle Tennessee. Throughout Tennessee, this is an issue. It's even more of an issue in the Appalachia area. This is a real problem. People are dying at a frightening pace. And most of the reason why people are now, we're seeing such an increase in deaths related to opioids is because when people who have become addicted, unfortunately, they can't get enough of their fix. and they end up in a situation where they seek out something stronger. And in a lot of cases now, that's become heroin, which is an opioid. Obviously, it's a illegal opioid, but heroin, or a product called fentanyl, or some of its. So fentanyl is a legal drug, and it's used heavily in surgical settings and things like that. But there's clandestine laboratories to make fentanyl almost kind of like meth. So it can be like street-made fentanyl or imported fentanyl. A lot of times from China and places like that. And they seek out these drugs that are extremely high power and that their body can't handle, and that's how we end up with an opioid overdose. And it's an extremely scary thing to have happen to somebody that's close to you. And so really the answer to this is a slow reversal of those prescribing patterns that we've talked about, and that has happened somewhat, but also just for lay people to be aware of what an opioid overdose can look like, and potentially you never know when you might need to help somebody who is close to you. And so like myself, I keep Narcan in my closet, where if anybody that is anywhere near me, at the time when I'm at my house, has an opioid overdose, I have something on hand that I can treat them with. And so even lay people can request to have a prescription like that and keep it on hand if someone that they love is using opioids or something like that. Even if they're using them perfectly legally, it's a good idea to have that and know how to use it to help them.
Yeah. So let's talk a little bit. You mentioned Narcan. Let's talk a little bit about the cost of drugs, the rising cost of drugs, because, and my understanding is not where it needs to be for this conversation. Obviously, I'm a biblical scholar, not a pharmacist. That's why I have you talking about this. But my understanding is that you can go and request Narcan or get it either free or very cheap.
Yes. In a lot of cases, like community outreach programs provide it for pretty cheap.
Yeah. So you have a drug that can save the life of someone who's overdosing, which is a great thing. I don't want it to be taken that I'm saying that's not good. But then there are people who need insulin for type 2 diabetes. There are people who need EpiPens to carry with them for a number of reasons. And these drugs cost so much, and insurance companies aren't doing their job. It's a lot of different factors going into one problem. So I wanted to ask you to speak to that a little bit about the cost of these drugs on the rise, and as that pertains to ethics, do we have an ethical obligation to make these drugs available for all people, or is it on them to make sure that they have the money, the insurance, the situation, or can there be a blend of both?
Absolutely. So I think that there's room for there to be a blend of both, but certainly my personal ethics comes into this, and I'll definitely comment on that. But first off, let's, not to lay blame necessarily, but let's kind of indicate who the players are that have caused this situation.
Yeah.
So you basically have two sides of this coin. You have manufacturers who want to make as much off of their drug as possible.
Sure.
And you have pharmacy benefits managers who are kind of a middleman between insurances and their the patients of that particular insurance, and also a middleman between the insurance and, say, the pharmacy. In this case, it would always be pharmacy. It's a pharmacy benefits manager. And essentially what you have in the case of a pharmacy benefits manager, or as we like to call them, PBM, you end up with a group it's in their best interest to collect as much as possible from premiums and pay out as little as possible in order to reduce copays on drugs. And there's somewhat, I won't go into the details of this, but just to put it mildly, there's somewhat of a battle that goes on constantly between manufacturers and pharmacy benefits managers, because the manufacturer might say, well, we're going to raise the price of our drug, and the pharmacy benefits manager might say, well, you can do that, but we're going to put your drug in a different tier, and it's going to cost all of our patients a lot more money, and we're going to make your competing manufacturer a more preferred product. And so there's just this constant back and forth. It's been a decades now long battle kind of between these two entities. And you have people like me, when I worked in community pharmacy, who were stuck right there in the middle of it. And you could say, was on the front lines of some of that. Right, and I'll say I was right along in there with my patients. I wanted them to receive what they needed, because it didn't matter to me what the price of the drug was, and it didn't matter to, at the time I was an intern, but it didn't matter to my pharmacists. My pharmacists weren't going to make more money by selling a high priced drug to the patient. They want their patient to get it for the best price possible. And so where my personal ethics comes into this is when I see somebody in this situation, maybe at the pharmacy, who has come up needing one of these life-saving drugs, like say their insulin that they've been on forever, and now the price has changed and they're just really stuck. I have the knowledge that there are patient assistance programs that are offered directly through manufacturers. You could say out of the goodwill of their heart, but the reality is that it's more of a marketing tool for them.
Yeah.
But still, it's something that could potentially get the patient the drug for little to no cost. And so I feel obligated to make sure that I inform them about that. And in a lot of cases, there is somewhat of ignorance on the part of the prescribers of these medications, and knowing their patient situation. And they know that these programs exist, but sometimes they don't know when their patient needs help. Mm-hmm. And so in my case, I try to say, hey, look, here's an option. Reach out directly to the manufacturer. Go to their website. Look for options. I tell them, I don't want you to pay any more for this than you have to. So let me provide you with these resources. And that's where my personal ethics come into this. Because does it take extra time to do that? Absolutely. Especially if I'm going to walk them through any parts of the process, that's going to take some time to do. But I want to see them get that medication. It's not my goal just to move them through as quick as I can. Yeah. And so I've had some incredible examples set out in front of me by pharmacists who have done that and taken those extra steps and done those things, and I really admire that, and I'm glad to have those examples.
Good. Let's wrap up here with the last question, and I think you were alluding to this somewhat in the first question, but when you talk about drugs and prescriptions, I see the commercials on TV, and it always seems to be like, this will cure your sore big toe, but you could get cancer. So how do you, as a pharmacist, talking with your patients, weigh the benefits? And I'm coming at this again from an ethics standpoint. This is an ethics class, but at what point do you say we may need to try something else because the benefit does not override the harm? And I gave the example of Accutane. I was on Accutane for a long time, way longer than I was supposed to be, and it wrecked my body because my doctor put me on it for longer than I should have been. But unfortunately, I'm a man and not a woman. It would have been far worse for women. So at what point? Because to me, like using Accutane as an example, and if you're listening and you don't know what Accutane is, it's an acne medicine. I'm sure it's used for other stuff, but for me, it was an acne medicine. And it's a pill, but it will wreck your system. Like, it's a very high potent drug. So for me in high school, was it worth not having acne and also wrestling with suicidal thoughts? So I'll turn it over to you to speak to that, weighing the benefits and the risk.
Sure. So the first comment before we get into the particulars of any specific drug or anything like that, the first comment that I'll make, and something that it's always my duty to keep in mind, and really this goes for any medical professional, particularly every drug decision is a risk versus benefit decision. There is no completely risk-free drug. Now, I will qualify that by saying that, let's use Benadryl for example. If I take Benadryl, let's assume that I'm not anaphylactically reactive to Benadryl, which would be obviously incredibly unfortunate because Benadryl is something that you usually take for allergies. But
exactly.
Believe it or not, there are people out there that are allergic to it. Very rare. But for me, in my circumstance, if I take Benadryl, the risk versus benefit that goes through my mind is if I take this, I know I'm going to be very sleepy. And part of the reason why Benadryl is available as an over-the-counter drug is because essentially the FDA has deemed it appropriate that the public can make a risk versus benefit analysis on something like that for themselves. That's mundane enough that the public can read the instructions and make that decision for themselves. If that's an acceptable use, or if that's an acceptable effect in order to dry up your sinuses or whatever is currently ailing you, then you can make that risk versus benefit analysis right there for yourself. But obviously there are some drugs in which there are a lot of risks associated with them, but in some cases that's because there's also a lot of benefit that could potentially be associated with them. And so you kind of made an example, and it's often one, being in the medical field, we'll joke about this even ourselves, where you hear a commercial on TV and it's just this whole laundry list of these terrible sounding things that may happen to you. And admittedly, before I was in pharmacy school, my thought often went to, why on earth would I ever use a medication that had this laundry list of issues associated with it? Well, come to find out, a lot of times, in those circumstances, the drug is obviously put through rigorous testing in order to determine its safety and efficacy before being released to the market. And in a lot of cases, the drug manufacturers are required to include warnings about almost anything that happened to anybody who was taking that drug in their trial. So somebody might have died in a car accident during their trial, and if it was a very large trial, there might have been several people who died at some point during that trial, and that might reach a threshold where they have to say there's an increased risk of death with using this medication, despite the fact that most of those deaths could be explained as to why they occurred and that it really didn't have anything to do with the drug. But they're required to put that information out there. And I think that's good in a lot of ways, because that means that there's in a lot of cases, that eliminates some of the wiggle room for maybe something to be hidden that could be associated with the drug, and that they really wouldn't want people to know about. And so just by requiring them to put everything out there like that, it is kind of important. So that's kind of some commentary on that, the typical commercial that you might see on TV and hear that whole list. But getting into, we'll use your Accutane example as, specifics. And first off, it sounds like you, of course, had an experience with it that was less than ideal. Yeah. And it sounds like you understand maybe some of why that happened. You acknowledged that it sounded like you were on that product for far longer than the normal person would have intended to have been.
Yeah.
And so, but using that example specifically, and I'll go ahead and quantify this as I'm going to try to come at this from assuming that it is prescribed and monitored and used how it's intended to be.
Right.
It can be done so in a safe manner.
Yeah, sure.
So, like for a drug like Accutane, it has one of the most easily recognizable what we call REMS, or Risk Evaluation Management Strategies, programs. So a REMS program that's out there, and it's called iPledge. And so for the iPledge system, basically there's a corresponding responsibility from both the prescriber and the patient in order to make sure that everyone is fully informed about the risks of that medication, which, just for anybody who doesn't know, particularly females that use that medication, there are very, very devastating birth defects that are associated with using that medication while pregnant. And there can even be birth defects associated with a male who is taking that drug and who conceives a child with a woman. Even if the woman was not using the Accutane, the male was, there can be birth defects associated with that. But certainly with females, there's much more of a risk. And so that REMS program is primarily designed to ensure that nobody who is pregnant or who may become pregnant uses that medication. And so that's where essentially the medical community and the manufacturer has identified that this is the major risk. This would be one of the most devastating things that could ever happen to somebody taking this medication. And so in order for us to ensure that patients can use that medication and receive the benefit from it and do so safely, we've put this program in place. Now, not every drug has a REMS program. Some drugs, it's incumbent upon the prescriber and the pharmacist, and to a certain degree the patient, to ensure that all parties are informed and that the benefit truly does merit the risk. So, usually that can be accomplished by making sure that there's good communication between the prescriber and the patient, and then when it comes time for them to actually receive the medication, between the pharmacist and the patient. And really that's just about making sure that everybody attends to their legal responsibilities in the matter, and making sure the patients are fully informed. So
yeah. Well, Clay, I appreciate you being here and talking to our students about this. Our book is over half of medical ethics, and so I think you've shed a lot of really good light. I know I've learned a lot sitting here in the past 30 minutes. I called you Clay. I should call you Dr. Mitchell.
Clay is perfectly fine.
I've known Clay since he was in high school, and Clay's a great guy, a great man of God, and I'm very proud of him. I'm proud to call him a friend. With that, we'll close this particular interview. I hope that you'll continue to watch other ones on other topics. Several good things to learn here from people who are actually involved in the actual ethical issues that we're talking about in our book. So again, Clay, thanks for being here. And guys, make sure that you're staying on top of your work and doing all that you need to do. We'll see you in the next video.